Con eso vamos a hablar de CAD and Diagnostic Testing Strategy with Flurpiridaz. And I'm going to give you a little breakdown of what we're going to do. We're going to talk about the basics. What is CAD, how it affects the community, how it affects the healthcare world, the resources that are invested in it. And then we're going to talk about the new agent, Flurpiridaz, and how it benefits the patients, what kind of patients are going to benefit mostly from it, and how you can do your patient selection. And then we're going to do other talks about the technical aspects of Flurpiridaz. And then towards the end, we're going to do some case studies. If you have any questions, I will be more than happy to answer them. If some questions are off label, I will have to answer them privately, one-on-one. Okay? So thank you. And with that, let's go ahead and get started. I have the clicker here. So first, a disclaimer, I do work for GE Healthcare as a medical advisor. So the information and material here is specific to GE Healthcare, and we're not implying anything to any products that are not manufactured by GE Healthcare. And the biggest thing is we want you to utilize your own expertise based on this information whenever you're engaged in the practice of medicine. And we do not recommend using the products outside of the prescribing information. We do have a link there if you're interested in learning more about Flurpiridaz. But let's talk about one of the basic things. What is CAD? CAD is the leading cause of death globally. Coronary heart disease, cerebrovascular disease, PAD, rheumatic heart disease, congenital heart disease, you name it. There's so many of them, but it's the leading cause of death. And in 2020, which is the last year we have complete data, coronary heart disease was the leading cause of all cardiovascular disease at almost 41%. 42% after that, we had stroke, CVD, high blood pressure, heart failure, and disease of the artery. So all these are considered cardiovascular disease. They're all connected to each other. And CAD is, like we said earlier, is the most common cause of death in the US. And the process of CAD, this is very important, could be silent or it could be symptomatic. And it's just transient or prolonged decrease of oxygen. And when we say it's silent, it's because sometimes you'll have patients that have CAD, but they don't have any symptoms. So it's important to keep that in mind. Let's talk about CAD, and let's talk about the range of CAD. The range of CAD can vary. You can start with patients that are completely asymptomatic, but you can have a patient that is asymptomatic and they had an abnormal test, whether it was a calcium score, just a plain treadmill, SPECT, CTA, but the patient is completely asymptomatic. We have those patients. And then you have a group of patients that have what we call ANOCA, INOCA, or MINOCA. ANOCA is basically they have angina with a non-obstructed coronary artery. And those patients, we see them sometimes, they'll come see you and they'll say, Dr. Salduendo, I'm having chest pains, my left arm hurts, there's an elephant sitting on my chest, I really can't breathe. So you run a SPECT and it comes back clean. There's nothing there because there's no coronary occlusions, there's nothing on there. But they have true disease, and we're going to talk about it shortly, and that's one of the advantages of Flurpiridaz. From there, you move on to patients that they do get symptoms, but they're stress-induced, whether they decide that they want to go play some tennis, or they want to go cut the grass, mow the lawn, or be active, and as soon as they start getting active, they start getting the chest. And those patients have obstructive CAD. And then you have patients that have been already stabilized, that it's after they have the acute coronary syndrome, or they had a PCI or a CABG. Those patients are already stabilized, and then towards the end, you have patients that have left ventricular dysfunction and a failure this is caused by ischemia. It's a failure of ischemic origin. And then on the right, you can see that there's two types of disease. We have epicardial disease, and we have microvascular disease. And what I want to do, so I want to put it in context so we can see what we're talking about. Epicardial disease, we're talking about something you can see on a SPECT. You have your main coronary arteries, you have your left main, and then you have your LAD, you have your left circumflex, and your right coronary artery disease. You run a SPECT and you can see there's blockage or there's stenosis because there's contrast. Let's say you have stenosis on the LAD, well, that area is going to be darker on the images, but the other two are going to be pretty bright. That's epicardial disease. But then on the other side, you have microvascular disease. Microvascular disease has nothing to do with epicardial, nothing to do with the main coronary arteries, and it's invisible to SPECT and to coronary angiogram. And then there's different ways you can find it. You can find it structurally, or you can find it functionally. And we're also going to talk about the type of test, because there's times when you want to choose a structural test, like a calcium score or a CT. Those are considered structural because you're looking at the anatomy. And then you have functional tests where you want to see the physiology of it. So there's times when you want to decide which one you want to do. Now, when we're talking about microvascular disease, you're going to have the same classic symptoms. You're going to have chest pain, you're going to have your shortness of breath, you're going to have fatigue and dizziness. Same symptoms you would have with epicardial disease. The only difference is that you won't be able to see it on SPECT or coronary angiogram. And what we're going to talk more specifically here, we're going to talk about microvascular disease. So this is one subset of patients that are going to benefit greatly from Flurpiridaz. And like we talked about a little while ago, you have patients that have angina, but they don't have an obstructed coronary artery. So we call those patients ANOCA patients. From there, they graduate to INOCA, where now they have ischemia, but they still don't have an obstructed coronary artery. So now you have INOCA, and then from there they graduate, which we don't want to see, to MINOCA. Now they have a myocardial infarction, but they still don't have an obstructive coronary artery. So it's a process, but it's not limited to that, because then you also have patients with cardiomyopathies. You have patients that have, capillary issues, your rarefaction on your capillaries. And then you have patients with heart failure, but they have preserved ejection fraction. And that's the classic definition of microvascular disease. They have heart failure, but their ejection fraction is preserved because their epicardials are healthy. The problem is microvascular. Then you have patients that have regular obstructive CAD. So if you have a patient that has epicardial disease, you can pretty much bet that they're going to have microvascular disease, because for it to affect the epicardials, it's going to affect the microvasculars. You have patients that have iatrogenic issues. Again, it's a classic microvascular disease. You have patients in acute coronary syndrome. What you'll find out is that most of the times in acute coronary syndrome, it was caused by microvascular disease, so they have pre-existing microvascular disease. And then you have patients with Takotsubo syndrome. Again, this is the definition of microvascular disease. It's pre-existing on the microvascular disease. Now, what I want to do is I want to point this out to you, and I mentioned it earlier, but it's very important. This disease is invisible to coronary angiography or conventional SPECT. And that's why you'll have those patients that they keep coming back to you and they're having symptoms, but you don't find anything. Because right now it's invisible with the technology that we have with SPECT. You're just not going to see it. And then you're going to see it in conjunction with diffuse atherosclerosis. So they're going to go hand in hand. If you have a patient that has that, they're going to have microvascular disease. So this is just something that you want to keep in mind when you're treating patients, and you want to say, this is a good candidate for microvascular disease. And that's a good point to make to perform a PET CT on this patient, on the cardiac. You also have, patients that have your basic coronary artery disease, and then they move on to microvascular disease. And what we want to point out is that microvascular disease, there's going to be times when we cannot manage it. There's things we can manage. We have the, risks that are modifiable. If the patient has high blood pressure, we can manage that. If a patient has dyslipidemia, we can manage it. There's a lot of things. The patient is not active. The patient, has a bad diet. The patient smokes. A lot of things we can manage. But then there's some things that come up and we cannot manage them, such as increase in age. There comes a point where it becomes a risk. Being a male, I was born a male. Naturally, I'm a higher risk of cardiovascular disease. My ethnicity, perhaps. Or basically, you see a lot of patients that their family history is just genetically speaking, they're just going to develop it. So whenever you have patients that have non-modifiable risks factors, we want to watch those patients for microvascular disease, because eventually they're going to develop it. There's nothing we can do about it. There we go. Yeah. So let's talk briefly about the burden of CAD, because we talk about CAD, but we want to put it in context on how it affects all of us. Not directly, but it affects all of us. So we have CAD, and we know that CAD is associated with substantial morbidity, mortality, and uses up a lot of healthcare resources. So more than 1 in 5 of the deaths annually are caused by heart disease. That's over 20%. 20 million adults in the US have been diagnosed with CAD, and more than 50% of the deaths associated with heart disease are attributed to CAD. But the one that scares me the most is the last one. We're expecting a 40% increase in that. And we're expecting a 40% increase across the board, not just on CAD. If you look at the bottom, we're expecting a huge increase in obesity, in diabetes, in hypertension. And those are major drivers of CAD. So if you think we're already at a point where obesity is a problem, hypertension is a problem, diabetes is a problem, it's going to get worse. We're expecting a huge increase on that. So this is going to eat up a lot of resources. So why do we mention this? Because Flurpiridaz is going to be a great tool for you to avoid your patient getting to this point. And we're going to talk about the ischemic cascade. Some of you are familiar with the ischemic cascade, some of you are not. But we're going to talk about it, and we're going to see that there's a point where you can start doing your cardiac imaging before they get to a certain point, and we can avoid it. But let's talk briefly about the guidelines for evaluation. How are you going to look at your patient, and how do you evaluate your patient? And this is classic. You probably know all of these, but we do have to touch it. First, you do your assessment of your symptoms and your clinical investigation. Then you're going to consider the comorbidities of your patient and the quality of life. Is the patient active? You know, do you have a good diet? Do they have high blood pressure, diabetes, all these comorbidities that are going to make it worse? And then you do your basic evaluation. You do your blood work, your baseline echo, a resting echo, an ECG. And if you think it's necessary, maybe a chest x-ray. And all that is great. Then you assess your PTP, right? Your pretest probability. You're going to assess it. And then here comes the good part. You're going to decide what kind of cardiac testing you're going to do based on that information you have, and then select the appropriate therapy based on symptoms and the event risk. We have a pyramid. On the very bottom, you have your patients that are asymptomatic and then low risk. And the reason we bring that up is because we want to keep patients here. We don't want them to get up here. Once they get to acute coronary syndrome, yeah, you can treat your patients. And a lot of times, you know, we don't see patient either because they never made an appointment or for whatever reason until they already have ECG changes, they already had an acute coronary syndrome, or you looked at their blood work, you know, you look at the cardiac enzymes and they're completely out of whack, and you run it 3-4 times to make sure they're okay. But once you have the cardiac enzymes on there, there's already damage to the myocardium. So we want to avoid getting to that point. We want to keep them on the very bottom of the scale. So here comes your guidelines for how you're going to decide which test you're going to do on the patient. And this is some guidelines put out by American Heart Association, ACC, SCCT, all these associations came up together with these guidelines. And you're going to base it on several factors. First, you're going to base it on the pretest likelihood of CAD. So you did all your pretest, and now you want to decide, do you want to do an anatomical testing or functional testing? And this is some guidelines here. If the patient has a low probability on the very top, the patient has very probability, sometimes you say, I'm not going to do any cardiac testing. You might do a calcium score. You might do, you know, some basic test just for risk stratification. You're going to do your ECG, but you're really not going to do, you know, a PET CT or a CMR or anything like that because of very low probability. But when your patients start moving to your intermediate or high, then you have to break it up. Is it a younger patient? And younger, we define it a patient under 65 years of age. That's considered a younger patient. A patient over 65 years of age, then it's an older patient. So then you look, is my patient 45 years old? Okay, so the patient falls right here. And he also has, I suspect that there's a lower probability. Well, then you want to do maybe a CCTA. That's going to be your preferred method. But if it's an older patient and you're concerned that because there's, more probability of CAD, then you want to do functional testing. You want to do your stress testing on that patient. Once you decide that, then you move down here and you want to figure out what is your goal on the testing. What are you trying to achieve? What are you trying to find out? So if what you're trying to do is rule out obstructive CAD or detect non-obstructive CAD, then you do your CCTA. But if you want to see, if you want to do some ischemia guided management, then you do your stress test, you do your PET-CT. So we're not going to talk about all of them, but that gives you an idea, a little bit of a, flow, so you can decide what kind of testing you're going to do. And this is for the benefit of the patient, but it also allows you to manage the patient properly. So this just circles it for you, whether you want to do CCTA or if you want to do functional testing. So here's the one that I really, really like. This is what we call the ischemic cascade. And this is the one that is going to show you how Flurpiridaz is going to benefit your patients, which is our primary goal, and your practice, and is going to help you manage them properly. So the ischemic cascade is very simple. On the x-axis, you have time. As time goes by, your patient is going to progress from being a normal patient all the way to having a myocardial infarction. And then, from being subclinical to clinical. But what we don't want is, we really want to avoid the top 5, but let's concentrate about the top 3 for now. I prefer to stay away from the top 5. But if you look at the top 3, we really don't want the patient to get there. But first, you have a normal patient here, and then the patient starts having some hypoperfusion. Patient might not know it. Patient's not having symptoms, but there is some hypoperfusion going on there. Maybe he has, some stenosis in the LAD or a microvascular disease, whatever the case may be. He's having or she's having some hypoperfusion, but nobody's aware of it. From there, they're going to move to some ischemia. Now you're going to have perfusion defects. Patient might still be asymptomatic. But here's the one that I really want you to think about. When the patient starts having metabolic changes. When the patient starts having metabolic changes, that's a red light that should go off. And first let me define metabolic changes. What do we consider metabolic changes? Insulin resistance, right? That's the big one. Dyslipidemia, hypertension, abdominal fat. And if you look at your patients, how many of your patients meet those guidelines? How many of your patients have metabolic changes, either are undergoing metabolic changes or have undergone metabolic changes? I'm going to risk it and say, from my experience, pretty much, a large percentage of it. So the key here is once you see metabolic changes, if you look at the appropriate use criteria, this is the time to start doing a PET-CT and PI. Because you can detect it here. Now you can detect the ischemia. You can stop it from progressing. If you don't, the patient is going to go into diastolic dysfunction. And then it's going to go into systolic dysfunction. And I'm not a fan of systolic dysfunction. Because once you get to that point, it's going to be harder to manage. But then from there, they're going to go to your ECG changes. So the patient comes into the emergency room. You run an ECG. You see it, some ST depression. And it's pretty large, 2 or 3 millimeters. And it's on 5-6 leads. So it's not an artifact. But by the time you're seeing these changes, it's a safe bet to say that there's some damage to the myocardium already. So we don't want the patient to get to that. And then from there, they're going to start having your classical symptoms. They're going to have your chest pain. They're going to have, the left arm pain, the shortness of breath. And then finally, if we don't do anything, they're going to move to the myocardial infarction. And this is known as the ischemic cascade. It's not a question. It's a fact. That's your patient is going to move from there. So the big advantage of Flurpiridaz is you start seeing metabolic changes, we need to start doing some PET-CT imaging of the patient. And the reason I say PET-CT is because, like I said earlier, if it's a microvascular disease and you do SPECT, it's invisible. If you do coronary angiography, it's invisible. So that's when you need to start doing your PET-CT on the patient on cardiology. And then, what ischemia is just a transient ischemic balance between oxygen supply and demand. That's all it is, but that's going to cause a lot of damage. So once we talk about the ischemic cascade, let's talk about SPECT. Now, we've already established that, microvascular disease is invisible to SPECT, but SPECT still has some benefits. There's some good things about SPECT, and then there's some things that are, on the negative side, but we need to understand, because there are going to be times when the insurance is going to say, you're going to have to do a SPECT. So we need to understand what a spec does and what it doesn't do and what the advantages and the disadvantages are. So spec, first of all, there's plenty of evidence supporting spec MPI as a workup and for risk stratification. So it's been a workhorse. It's been really good. It has high diagnostic, prognostic value for assessment of ventricular size and function, for wall motion abnormalities, and even for viability. And if you look on the right side of the screen, you can see a little bit of ischemia here. You can see how the dark areas here. You look to the resting, and you can see there's ischemia there. And then you can see the scar also here. So SPEC does a good job. It can help you, stratify risk. It can help you look at the epicardial disease. It can help you get a lot of things. What is the advantage of SPEC? It's widely available. And from what I understand, it's widely available here. Not a problem. You need a SPEC, you can get it done. It has high sensitivity. And it has improved sensitivity and specificity if you're just doing a plain exercise stress or a plain ECG. You can evaluate your perfusion, both ischemia and viability and function. And what are the negatives of SPECT? Well, you're going to have a lower spatial resolution. And we're going to touch on that because it's a big difference. You're going to have a lower spatial resolution. You're going to have a lot of attenuation artifacts, breast artifacts, diaphragmatic attenuation, motion. You have so many artifacts. And then there's limitations of relative perfusion imaging. And also, there's something that I like to bring up because people look at PET and they say, well, we're doing rubidium or you're doing flurpiridaz. You're giving the patient 511 keVs. Compared to, when you're doing a SPEC with technetium, it's only 140 keVs. So a lot of people are like, well, I don't want to give my patient that much. It's 511 keVs, 140 keVs, I'd rather do the SPEC. But in reality, when you do a PET-CT, the patient gets about half the radiation they get from SPECT. So SPECT gives them almost twice as much radiation than a PET-CT. So sometimes looking at just the number doesn't give you the whole picture. So it's just a fact. It gives you almost half of the radiation. And let's talk about PET-CT versus SPECT MPI. So what is the advantage of doing PET-CT? Well, first of all, you're going to have superior image quality. It's one of the best things. The tracer characteristics, you're going to have improved count statistics across the board. And then if you look here, with SPECT, you can detect defects about 12 to 15 millimeters. That's the threshold. Anything smaller than that, you're not going to be able to pick it up. And with PET, you can do 4 to 7 millimeters. So your spatial resolution is much better. Your image resolution is much better. Your diagnostic accuracy is much better. The timing of the test, when you're doing SPEC, I don't know what you guys are doing, 3 hours, 4 hours your patient's going to be in your clinic or in your hospital or in your lab. 3 to 4 hours was the average, when I was in the field doing that. With PET-CT, 30 minutes to 45 minutes and the patient's done, beginning to end. Get them in, get them out. A lot faster. And, you reduce the radiation exposure to other patients, to other people. You get the patient in, you get them out. So it has a lot of advantages. And then, like we talked about, lower radiation burden. So your exposure level for the patient is lower with PET-CT. And then the big one that I really like, you can do absolute quantification of perfusion. It has a high first pass extraction of PET tracers, which allows for a better flow over a wide range. So let's talk about the good things about PET-CT. You're going to have improved diagnostic accuracy. Your attenuation correction is excellent. You're going to have absolute quantification of MBF. Your myocardial blood flow, your reserve, you're going to have absolute quantification of it. And that's how you're going to pick up your microvascular disease, your multivessel disease, or patients that are having metabolic changes on the microvascular end. Short tracer half-life, faster procedure protocols. So why isn't everybody doing PET-CT? Right? Well, because there's some negative things about it. It's not widely available. It's just not. Either if you want to do rubidium, you have to buy a very expensive generator. So if you only want to do, 10 patients a week, it's just not going to work. You're paying too much money for that generator. It's the capital investment that you have to make is pretty large. The radiation exposure, it's lower than spec, but you still have radiation exposure. So some people take that into account. It was before, at one point, PET-CT was limited that you could not do exercise stress. But with Flurpiridaz, now you can do exercise. Rubidium, rubidium has like an 80-second half-life. So if you put the patient on the treadmill, you inject them, by the time you recover the patient, put in the camera, it's gone. You're not even going to have perfusion images. You're not going to have anything. Flurpiridaz has about 110-minute half-life. So you want to put the patient on the treadmill, put the patient on the treadmill. It's not a problem. And then, SPECT is widely available, like we said, but PET is very limited, a big investment on it. So that's the reason, but hopefully we're going to change that. And then just lightly, we're going to touch on, again, deciding. We talked about Flurpiridaz, but again, you have to decide what type of imaging you want to do. And when you decide imaging, you can decide to do non-invasive or invasive, and you can do anatomical and you can do functional. And that's what you want to decide. And here's the choices that you have. You want to do anatomical, or do your CCTA, or you can do it invasively also. You can do an invasive coronary angiography. You can do intravascular ultrasound. You can do optical coherence tomography. All those are anatomical strategies, but the bottom ones are invasive. And then on the right, we did put fractional flow reserve as invasive, even though we'll talk that you can do it with CT. But, originally it was done in the cath lab, so that's why we put it as invasive. But you also can do functional imaging strategies. You're just a plain treadmill. Back in the day, we used to call it just a vanilla. Put the patient on the treadmill, do the ECG, that's it, no imaging. That's just a plain exercise. You can do a stress echo, you can do a MR, you can do a lot of functional images. And you're going to base that, if you look on the bottom, you're going to base that on your patient characteristics. What best suits the patient and what is the best fit for what you're trying to find out. And then your suitability and your local availability, because you can say, well, I want to do a PET-CT, but if it's not available, then it's really not going to help you. So you want to look at the availability, you want to look at the expertise. So let's say you have a PET-CT for cardiac available, but do you have a person that can do it, read it professionally, expertly, and they have the background? Then do it. And then, of course, your pretest probability. And this just touches on the same thing, the anatomical modalities. But what I like to point on this one here, if you look at this one here, and I'll put a box around it, is that there's distinction between anatomical and functional modalities. It's important because you can do an anatomical test and you can see stenosis, but that does not mean that there's ischemia or even some hemodynamic significant changes on there. So you can see the stenosis, but unless you do a functional test, you don't know if there's ischemia. If it's because we've seen it, that patients might have stenosis, but there's really nothing wrong. It's still enough flow going in there. So just keep that in mind. Whenever you do an anatomical test and you see some stenosis, there's no guarantee that is going to affect the hemodynamics on the patient. So the choice between anatomical and functional modalities depends on the clinical questions that you want to have answered. So that's basically here. So that's going to conclude the first section that we want to talk about.